10 days ago, and our intention is to go ahead with the left main stenting with plaque modification of the LCX as well as LAD. But unfortunately that patient is suffering from fever. Because of that our intention is to show in the next session. So right now as per the schedule, we wanted to show one LAD mid lesion involving the bifurcation. There is a very short segment lesion of the diagonal, that is hardly less than 5 mm, and though lesion is there but less than 5 mm. And the important thing is 3 diagonals are there. Diagonal 1, 2, 3 is there. If it is only single diagonal, if you are losing the diagonal and if the area supplying more than 10% area, that is more important. But here anyhow our strategy is to go to do with the imaging acquisition. And just now already the program is started by Dr. Reddy, senior interventional cardiologist from Kim Sunshine, and we have also have a senior interventional cardiologist, Dr. Shailendra Singh. So both will be guiding, and we will be discussing while doing case also. This case initially we will acquire the OCT imaging. Today we will try to use the new version of the OCT catheter, the OCT OP star. So the advantage is it's a more trackable, more flexible. You can reach to the distal lesion, you can go through the tortuous lesions, and there are salient features of that particular catheter. The new version of the OCT catheter, it has 3 layers OP star, where penetration capacity is more. The advantage is its shaft is more rugged, more flexible. You can reach forces, trackability forces, go through the tortuous lesion, and the guide wire exit. There are salient features also of that particular catheter. It's more aligned with the tip is tapered. Catheter has 3 layers, additional where penetration capacity is more, so that it will not bend. Shaft is more rugged inside. Penetrating forces, advantage of the more image marker. The guide wire exit at the also. It's more aligned with the marker is there. Catheter that with additional reinforcement previous version, so that it will not bend. Lens is about 2 to 3 mm behind that, and advantage marker, of the but here image just marker, the marker only, wherever the pragma marker is there. Another advantage, usually this catheter previous version marker is the far behind. Lens is about 2 to 3 mm. You can acquire 75 marker. So here just length of coronary artery, just the marker very effective only. Even you can place the another advantage distally, this catheter, and the distal marker is another advantage of this catheter. You can acquire 75 mm. So length between the length of coronary artery and access very effective. Distal tip is only even you can place the previous version, and the another advantage of this catheter, the 27 mm versus 23 lens, and so that you can distal tip is only 23 capture some more length. Previous so these are the advantages of this OCT catheter. About 27 mm. We wanted to use 27 mm versus 23 catheter, so that you can behaves and capture some more length. So these are the advantages of this OCT catheter. This shows more this time high resolution the new version of the catheter, more clarity, more high resolution images compared to earlier version, and more trackable. This shows more high resolution even distally images. You can acquire more clarity, more high resolution of the catheter is much and more trackable earlier version. And so these are the advantages even distally. You can acquire longer. And so we will acquire the OCT. After that we will take the opinion. So these are the advantages of the Dr. Star, Vijaykumar Reddy. We will acquire the OCT. After that we will take the opinion. And after that we will assess any need for plaque modification. Vijaykumar Reddy, the patient only needs cutting balloon. And after that we will assess any need for plaque modification. Rotor orbital. The patient only needs acquiring the image, we will take the opinion. Then after that once we do the plaque acquiring the image, we will take the opinion. We will implant the stent. After that once we do the plaque modification, distal landing zone. Lesion length will assess, fractional distal landing zones, lesion length will assess, stent size will choose the according to the imaging, stent size plan the provisional stenting imaging. Once we do the plan the provisional stenting, we will optimize. Once we do the provisional stenting, NC balloon optimize with the once NC balloon dilatation implantation is completed, we will see the side implantation is completed. We will see the side drive flow. We will do if anything is there, we will do animal kissing is required or not, is required or not, to go ahead with that. And at the same time, once acquired we will see for the that is mala position is there or not. and under expansion there are not, and at the same time rule out any medial edge dissection and see the any geographical miss is there or not, if those are there we'll try to and finally we'll end the procedure with image guidance. So now anything is there, then we'll proceed with the case.
Now the initial plan imaging was the upfront single stent strategy, the provisional stenting, pre-imaging, then after imaging, then we can do the same MRI anything.
Pending అవన్నీ OCT
decided after OCT.
ఇంకోటి give another ఇది వేసుకుంటలే ఏషియన్ వస్ట్ కమ్ అక్కడ స్టార్ట్ చేయమని డిస్కషన్ అయినాక దెన్ విల్ ప్రొసీడ్ హియర్. First we'll discuss the so much resounding, brother. It's okay. Just go to the angiographic views. Brother, show me the angiographic views. Brother, go to the angiography. You can see the right corner. Dominant right corner. Right corner is absolutely fine. Though areas of mild disease, it's not very significant. There is no significant disease of the right corner. Then go to the next view. There is a difficulty in engaging. Go to the next. Now you can see the LCX is not having any significant disease. Though there is a mild narrow LCX of the mid LCX. Asthma is fine. Go to the next. LMC is looking fine. Next. Now you can see the freeze and frame by frame. Go back. See the mid LED. You can see the mid LED appears to be fine. Distal LED also appears to be fine. Mid LED just after first branch. Here diagonal branch is not looking very big. There are three diagonals. You have to consider whether side branch is important. So lateral area is distributed by three diagonal 1, diagonal 2 and diagonal 3. When three branches are there, the area of distribution of the one branch, even if it will be less than the myocardial. Any ischemia more than 10% is clinically significant. But anyhow we'll try to protect with the side branch. Wiring already we placed the wire. You can go to the next view. Now we can see the diagonal side whether to go with side branch stenting appears to be less than 2.5 almost less than 2.25 mm size, and the length of the side branch is less than 5 mm as per the criteria indication. There is no indication for side branch stenting. Only go ahead with the provisional stenting. Keep the jailed wire. That time if you are going to lose the side branch, then you can pass the balloon and do the kissing. The flow is good. If the flow is good, no flow limiting dissection, and residual stenosis is not very significant. That time you can finish the case. Otherwise you can go with the provisional. You can go with the extend T-tap stenting. But I personally feel we'll keep the side branch wire. We'll go with stenting. But we are going with the OCT catheter. Go to the next. Already we wired the both LED and diagonal. We wired the LED and diagonal. Now we are taking the OCT. That is new version catheter. Just now already I highlighted all the features of the OPSTAR. And we'll go with we'll acquire the image first. We'll see the calcium score and CT is about 264. There is a moderate calcium. Now we are going to acquire the image. And let me introduce my team members. Dr. Pranay, Dr. Partha. Both are very good cards. Dr. Bain and and Prashant is there, the Cadil is another, Vasu is there, and Venu both are head technicians, and they are very helpful, they have a vast experience. So with this note, let us acquire the OCT image. Slight to pull, no need to take that much length. That would be fine. Take forcible injection. That's okay. You can knock few more. Ready? NTG given, huh? Ready. Go ahead. Force. Wait. It will move. That's fine. Come. Now you see already. Most important thing, always give NTG prior to acquiring the OCT, and the same purge the catheter. Side port should be purged continuously while injecting, and the pressure of the contrast should be adequate to clear the blood from the coronary artery. If you don't clear the blood, if the blood is there, you will get lot of artifacts. So the image is absolutely very good. I am very satisfied with the images. Go to distally. Move. See, move forward. There is some wait. I will describe in detail. Go back. Still go to the end. Now you can see there is some fibrous plaque, but that fibrous plaque is not that significant. Luminal area is a 4.4 square mm. Just come proximally. Just step by step proximally. You can see there is a wait here. That is a diagonal branch. You can see the second diagonal branch. You can see very clearly, and then move forward. Move. Now you can see the area is a 5 square mm. Again fiber. There is a eccentric fibrotic plaque with some areas of calcification. You can see the above. That is called a spotty calcification. Spotty calcium. By definition, it should be less than 90-degree angle. See another side. There is a fibrotic plaque which is eccentric. Go to there. But luminal area 4 square mm. Go to the move. Now you can see there is a calcium eccentric fibrotic lesion. Wait, here you can see the very tight narrowing, that 1.56 square mm. If you take any criteria based upon the OCT, and they are mentioning like a high risk features of plaque, like a more lipid content, more macrophages, vasovasorum, spotty calcification, and thin cap fibroatrium. If these are there, that is prone for rupture. So lipid rich plaques are more prone. And here, and all studies have shown, like almost more than dozen studies are there correlating with FFR and OCT mean luminal area. But mean luminal area, some studies have quoted less than 3.5, some studies less than 2.8, but every study even less than 1.8, invariably it will be positive. 100% specificity and sensitivity, but is 2.5 above or between 2.5 and 3.5, we don't know. It may be positive, may not be positive, but sensitivity is more, specificity is less. So, but less than 2 square mm, it is definitely FFR positive lesion, very tight lesion, very critical lesion. It has to be stented. You can see the cholesterol crystals in the lower left border, that whitish lines. You can see very clearly cholesterol crystals. You can move. There is this is the area of the diagonal branch. Move. Yeah, sure. See, this is all more of a fibrotic plaque. You can see the then move. Side branch, move. See, and can septal branches are diagonal branches. This is again fibrotic plaque, more of a fibrotic plaque. I can see, move. See, now we are coming to the proximal landing zone. Here 7.1 square mm. So 7 square mm. Here relatively healthy zone. Go to the 40. Come to the left main. 6.9, 5.76. So proximal LAD. Everywhere area is more than 5.7. Now this is LCX and LAD ostium. Then move to the LM. This is coming to the LM area. LM area is showing 14 square mm, 13 square mm. Though there is a fibrous block is there, but it is not that significant. the plaque, the mean luminal is absolutely fine, that is 13.7 mid shaft. Then ostium we are coming, that is 15 square mm, and this is artifact, but almost 16 square mm, and 16 square mm the area will be almost 4 diameter will be about 4.5. Then that is the reason now our landing zone should be move towards the LAD, move toward the here the area 7.6, no need to intervene here, 6.1, 5.8, this is also good area, move 5.9, move 6.2, good, no need to intervene, 7, no need to intervene, 6.3, 5, now you see here plaque started, 3.8, will take the landing zone 5 mm proximal to the disease segment, then 5 mm come towards the left main from here. So, here we will take the landing zone, freeze, this is the proximal landing zone, then from there we will go distally, go to distally, this is all disease segment, go, move distally, beyond 10, 4.6, we will take here as a landing zone, 5.28, it is a good landing zone, we can land just before that diagonal branch. So, what is the length? 31, slightly go, we can take 33 mm stent, that is also 5.58, absolutely fine, we will take 33 and we will proximal to the diagonal, we can land and we will take 33 mm, and the diameter how to select, take the luminal diameter. So, this is ELD diameter, that is slightly go away, it is almost 3.5 vessel, vertically you come, still down, see almost average diameter is about 3.5, we will take 3.5, come to the proximal landing zone, proximal, there you EL diameter you take, slightly away, almost it is coming to 3.8, vertically also you take, from there outside that black, still you have to move it down, still. So, now almost slightly away, almost 4, so roughly proximally 4 mm diameter. So, we are going to choose the 3 mm diameter stent, 33 mm length based upon the OCT parameters. So, this is a case with thick fibrotic plaque with some areas of calcium which is not very significant. We will take cutting balloon before implanting the stent. Take the cutting balloon 3.5 Wolverine, you can take Wolverine. The advantage of a cutting balloon over NC, cutting balloon have a micro blades. So, dissections are very clean, nicely cut dissections, so that the slippage of the balloon is less inflammation and better healing, and the chance of developing intramural hematoma less likely with a cutting and scoring balloons. If you do NC, what happen in the fibrotic plaque, if eccentric plaque is there, when you go with high pressure, sometimes it can lead to dissection and extension of the intramural hematoma, whereas the cutting balloon and this one, it creates a clear cut incisions, and that is the reason the restenosis rate is also slightly less, and moreover expansion of the stent will be much better. More important thing, slippage of balloon is less, and at the same time the formation of the extensive dissection with intramural hematomas are less likely because of the controlled dissections. Are they showing the this one also, brother? They are showing monitor. Yeah, that's. You can show the monitor now. Yeah, go ahead. Give a small injection. Let us see the distal landing zone. Push the wire, catheter, engage properly. Small injection. give an injection. I think it's fine, but wire you can push further. If you want, we can place further. This is the side branch, one of the side branch. It's not in the actual LED. The core should be this side. It's okay. Dilate it. After that, you can replace. Do it. What is the length of the cutting balloon, brother? 15. Yeah. Pull it slightly. A small test. Give a proximal edge check once. Give a small test. Yeah, that's fine. You can dilate it. Yeah, remove it. Take the stent, brother. 333, 3.5, 3.533. No, don't come too proximal. You have come. No, already you have reached too proximal. No, remove it. No, you have gone too proximal. Then 33 will not be sufficient. Take. Take one injection. If that is the case, replace it. Take one more OCT, one more ECG. Take one scene. That's fine. We'll take one more OCT. Then we'll decide. Wire position it properly. Let me take one more OCT. Remove the balloon so that you can place it nicely. And push. Otherwise, I will put it. No, I think some wire shape might have gone. Put this. Put this one darker. Put it darker. Leave it. I will do it. Yeah, brother. దగ్గండి ఒకసారి దగ్గండి మంచిగా దగ్గండి.
OCT was done. OCT shows mostly it is a fibrotic lesion with spotty calcification. So no need for any plaque modification with rota or orbital or IVL. So cutting balloon, Wolverine cutting balloon was 3.5 into 15 Wolverine was taken and it was dilated. The advantage of Wolverine cutting balloon is easily trackable. We can go up to high pressures unlike the conventional cutting balloons. So based on the OCT, the stent size should be around 3.5 mm from EL to EL and the length is around 33 mm with proper landing zones. That should be the strategy. Now after doing the cutting balloon, they are taking one more OCT to know the results. Afterwards, we'll once again communicate.
Then you can start here. injection. Keep just beyond the diagonal branch. Go. Wait, it will move, don't worry. Yes, absolutely fine. That's fine. Just whether project the OCT here? No, project the OCT here. Yeah. Sir, are you comfortable kada? That is a diagonal branch. So just proximal to the diagonal. See, area is no, just go distally. Go distally. So, inka distally, go distally. So, beyond the diagonal, we have a 5.4 square mm. Just come proximally. Don't hurry, slowly move. I am discussing. Go, just go. That is a diagonal branch. That is a diagonal branch. Just come proximally. Now you see proximal to the diagonal 6.25. That plaque burden is less than 50% and luminaries are good. So, that we will consider as a distal landing zone. Come proximally, move proximally. Now, see the 5. Now, you can see the cutting balloon into dissection. Move. You can see the nice cuts. You can move. Luminary area also better 6.2, 5.83. Move 6.47. Proximally you come 6. Move. Come. You can see the extensive dissection of the plaque also modified nicely 2.57. Initially it was 1.8. Now we gained almost 2.5 to 3.8. Go, move. Lot of fibrotic plaque. Come proximally. You can see. Come. Still there is some deep calcium, but I feel that is not that significant. We will go with the stenting and come to this side, go 40 towards 40, go toward the 40, towards 40. So, you see 40 level we have a dissection, slightly come toward this side, 38, come to 38, 42, come to 42, you see there is a dissection, come further, see here we have to land, still there is a dissection, move. Just rotate that upper one, rotate that one, bus. Then move forward, move toward left main. There are artifacts, that is no need to pay. These are all artifacts. We land at 40 level, then move toward this side, move. Shall we acquire one more image? Proximally it is not that clear, because that is artifacts proximally. We have to choose the nice landing zone. Now, our intention is to do the cutting balloon just beyond 40 only, but we moved up to the 43, 44. The importance of OCT, correct optimization, selection of the precise sizing of the stenting, so that you can avoid unnecessary extension of the stent. Take it just beyond diagonal, first diagonal, then we will acquire. Show the catheter, come nearer, go further, bus, we will take from here, that is enough. We will take up to, it should be blood free. When you inject, take a clear contrast. Any RBCs are there, they will obstruct the OCT rays. So, infrared rays cannot travel through the RBCs. That is the reason it may produce shadow or artifact. That is the reason blood should be clear from the coronary artery while acquiring the OCT. Okay, ready? Are you ready, brother? Okay, go ahead. I think You are ready. Ready, brother? Inject. Force. What's the move it? No, don't stop here. I told you that it will move. Artifacts stay. See, never. I will do it. See, always. It will take some time to move the marker. Keep there again. You wait until. No need to hurry up. Last 2 ml, wait. You are ready? Continuously apply pressure and wait there. Last 2 mm, leave it. Ready? Go ahead. Continue. Bas. That catheter should come here. Free, slowly. Move. You can move. You can see a lot of dissections. Move. Come to here. Come. That is LAD progmal. Come this side toward 30. Move. Here area is good. 3. Move. Good. So, almost we can leave 5 mm and you can go ahead. Then we will take a relatively longer stent. We will take 38 mm. Give 38. 3.5 38. Here cutting balloon moved progmally. If you do progmally, already you injured the endothelium. Then it has to be covered. Ideally, just beyond diagonal only, we should dilate and put the 33 mm stent. Here we are adding another 5 mm, which can be avoided. That is the reason when you use the OCT or imaging, use it to the maximum extent and utilize its how it helps. And you can minimize the number of stents, you can minimize the length of the stent. Go. Small test. Just before diagonal land, distal. Inko koncham 1 to mm land, slightly. Go test. I think that is fine. Okay. Not needed. Go ahead. Delhi. Small injection, lelo. You can take. But we are a comfortable zone. We are not bothered about the. No, we are not bothered. Already you are not beyond the LAD ostium. Okay. Even if you want to take the elevocardal, we are beyond the bifurcation. Elevocardal తీసుకోండి. Elevocardal shows the bifurcation. Whether you have extended, you are away from bifurcation. Inject. You see, you are above. Do it. Implant. Only do nominal. Will take 4 NC. A small injection. Give a small injection. Side branch is very well protected. Do again. Prolonged, keep prolonged. Fibrotic plaque, it has to be expanded. Maintain. Maintain for some time. 20-30 seconds you maintain. Deflate. One more give. Bhavunar ga sir, how are you? Good, good. Everything is going well, not to worry. ఏం భయపడాల్సిన అవసరం లేదు. Brother, give me 4 NC. 415. Come. If you have a shorter 8 ఉందా? 4 into 8 ఉంటే give 8. Pragma will do high pressure. Distally go with a nominal pressure. Take one cine.
Ready for injection?
Good, Sunny. Good, nicely flowing. This is proximal to the distal. It's okay, that's fine. Don't worry about it. Take the NC and dilate it.
What?
Diagonal wire, ఈ balloon వెళ్ళినాక before inflating remove it.
Will come from distal to proximal?
Distal to proximal. Distal go with very nominal. Only 6 maintain. 6. Distal 6, then mid go to 8. Then proximally will go slightly more. Just last 1 to mm avoid it. Do it. 6 maintain. Come proximally. Then go to 8. Up to diagonal do 8 only. Eight only. Go 8. Pull. Now pull the diagonal wire. Slightly push down. Do it now. 8. Pull the wire. Is it coming? Disengage the catheter. Not coming, I think. Wait. Now I will hold the catheter, you can pull out. If it is not coming, let me know. Is it coming? Yeah. So removing the jailed wire is very, very important, particularly fibrotic and fibrocalcific lesions. And if it is not coming freely, please don't apply pressure. When you apply the pressure, what happens? Stent gets deformed. It can lead to LSD. And it's very difficult to recross the vessel. So once the stent deforms, very difficult to place the wires and
Go to 10
even balloons. Yeah. Not beyond the edge, kada?
No, sir.
Come out. Inject.
Correct.
Inject. Inject. Fine. అయిపోయింది సార్. While disengaging, while pulling the balloon, engage it. Otherwise, inflated engage. Distally inflated. OCT, brother. See, both the diagonals are flowing well, and LAD no residual stenosis. Based upon the OCT, proximally we have inflated the LAD segment relatively with 10 to 12 atmospheres pressure, distally 6 atmosphere. See, the side branch is almost appearing like a before only. మళ్ళీ project OCT onto this one. It's okay, keep it there and put the OCT catheter. Go down. Still you can. That's fine. Slightly pull the wire. Avoid the pressure on the distal tip. Slightly pull the wire. That's fine. You are beyond the, brother, you are unable to see stent struts, kada? So we are beyond the stent struts. Now engage properly. Check once. If needed, slightly push it. Small test. Now slightly push it, not engaged. Now inject. Now this is fine. But I think we understand that. If you want to slightly, you can push it. That's enough. That's enough. Now, consistent force until that marker is there, no? It should move into the catheter. Until then, you apply the pressure, but at the same time, maintain last 1 to 2 ml inside the syringe. Okay? Brother, ready? Huh? You can on. Go ahead. Continuous. Good. Wait. Don't worry. You are absolutely doing well. Perfect. Now you can. This is a diagonal, distal diagonal. You can see very nicely. You can see the come proximally. So yeah, area 7.59. One area showing some red marker. Let us see there what it is. You can see this 8.69. Come. This area come. There is an artifact because that it is showing 1.7, but the actual area is good. So no need to just mark there. Keep it there. Take the diameter. Take the diameter there. No, inside stent only. Go to the stent border only. Yeah. Now you got 2.72 vertically. Come. Not 2. Almost we got a 2.8. Okay. Go to the next. Move. Here also we got a very good area. Next move. 7.3. Area is fine. That is the diagonal. Come back. Wait. That rotate. Rotate upper one. You can see the longitudinal axis. You will see the diagonal branch. Rotate. See, that is the diagonal branch. Rotate here. Still rotate. Wait. Just 1 frame back. Rotate in either direction. You will know the line, kada. Rotate. Just wait. That is the diagonal branch. You can see exactly where the marker is there. That is the diagonal branch. It is very well patent. Just move proximally. You see, nicely expanded. We got a 9.9. Here you can see the diameter. Freeze. Show the diameter there. No, brother. You have to see the stent border. Don't go outside the stent. That is the stent. So we got a 3.4 vertical. The diameter of the stent is 3.4, and the luminal area is 9.62 square mm. Absolutely very good area. Come to the proximal edge. See, nicely expanded. Come proximally. See, nicely expanded. That is the artifact. So there is no edge dissection. Nicely expanded. Go to the distal edge. I want to see the distal edge. So everywhere nicely expanded. No need to intervene further. Go to distal edge slowly. You can see the small edge dissection there. You can see, na? Come proximally. Come proximally. Yeah. Exactly. Go distally. There is a small dissection, but the criteria, as per the criteria, less than 60 degree, no need to intervene. We leave him conservatively with the medical management. I think we are going to finish the case, remove the OCT catheter, we will take the final shots. Pull out the catheter, both you can pull out. Both together pull. It will come, both together pull out. Yeah, now take the shot. Take nice shots, cranial, caudal. Brother, entire LED you show. Take good scene. See. Okay. You can see the diagonal slightly there is a pinching. That is because of the dissection extending to that, but that is not an important factor. That will, because as per the criteria is less than 60 degree, we can leave him conservatively. And the length also less than 3 mm, hardly 1 to mm length. When the length is less than 3 mm, no need to intervene. We'll go with conservatively. We'll continue aggressive DAP therapy. I think this case is a classic example where you can do the plaque modification and you can assess the plaque morphology, what kind of plaque, and you can see the device length and diameter, and finally after stenting addressing the maloperation, expansion as well as the medial edge dissection. This case was done through the right radial approach. Because bifurcation was there, we used slender, we used the 7 French guiding catheter. If any kissing or any T-tap stenting is there, that is the reason we have kept. Even we can do such type of case with the 7 French guiding, but male patient very good limb diameter of the radial, that is the reason we use slender and 7 French. Thank you one and all for paying the attention, and this patient definitely needs continuous, because the large LED area, large LED vessel, better to mention about the complaints of the DAP therapy and statin therapy, and standard guideline therapy should be given. Thank you one and all for paying attention. Right. మీరు చూపెట్టినప్పుడు స్లోగా ఫ్రేమ్ బై ఫ్రేమ్ చూపెట్టాలి.
Now the procedure is over. So, now the procedure is over. OCT has given good results. The stent was taken was 3.5 into 38, and it was post dilated with 4 NC, nominally distally and up to 12 atmospheres proximally. So the post OCT run shows there is no edge dissections, there is no malposition, and stent is well expanded. So this indicates especially in a long segment, bifurcation and calcific lesions, the role of imaging to achieve optimal results is good. The nicely done case. Thank you.